Okay, good afternoon. Welcome, everyone. I'm Jamie Waterall. I work as Deputy Chief Nurse at Public Health England, and it's my absolute pleasure to be chairing this afternoon's NHS Health Check webinar. I'm sure a number of you will know that I've worked on the Health Checks programme for a considerable length of time when I was working as a consultant in Birmingham, even pre-establishment of the formal programme, and then later into the department and then into PHE when it was established. So a programme very close to my heart, a programme that's essentially important. And during the challenging times that we've been experiencing over the last year, this programme will be even more important as we come out into that recovery period of COVID, because the presence or the focus on tackling behavioural, physiological, environmental risk factors that are driving the tide of particularly non-communicable disease, which will be as equally important as our focus we've had recently on communicable disease, is really important. So this session in particular, we're going to be focusing in on the NHS Health Check data extraction. And I'm thrilled to be joined by Professor Riaz Patel, who's Professor of Cardiology at University College London. And Riaz has been an absolute driving force and inspiration in the academic group that we established to oversee this NHS Health Check data extraction, but more importantly, its analysis and then its outputs in terms of publication and use across the health check community. So today's session is really going to focus in on looking at the outputs of those that 9.5 million people that we've managed to capture their information, either whether they've attended or not attended the health check, and to start to delve into what that data is telling us. So this is a really important session. It's fantastic colleagues have joined us. I suggest what we do is we get on with the presentation, but then there'll be plenty of time for us to get into some really good discussion, questions, answers after we've heard from Riaz. So Riaz, over to you.
Brilliant. Thank you so much, Jamie, for that kind introduction. So yes, good afternoon, everyone. So as James says, my name's Riaz. I'm an academic at UCL and working with a PhD team as part of this academic collaboration to look at the health check data in a bit more detail. And what I've been asked to do today is really just to take you through our first foray into this enormously powerful data set that we've acquired working with NHS Digital. What we intended to do is to have a series of papers or outputs from this data set, looking at different elements of the NHS Health Check. And the first is really just to give a national level overview of the programme as a means of also supporting interpretation of the dashboard, for which there's another webinar, I think, planned. And it's fortunate that sorry, next slide, please. It's fortunate that the work we've done has actually just been published. So if anyone would like to look at the figures or get more details, then I point you in this direction. It's open, so it's completely free, and the whole paper and the supplement are provided there with more details. So what I thought I'd do over the next sort of 15-20 minutes is just take you through that paper essentially and sort of highlight the key things that we've identified. And then at the end, hopefully we'll have some time for some discussion and questions. Next slide, please. So I'm sure I don't need to spend too much time explaining to this audience about the importance of vascular disease, cardiovascular disease, particularly in England and in Western nations. Back in 2009, there was a huge focus on this from the government at the time. And there was an ambitious program of vascular checks launched to try and prevent 9,500 heart attacks, 4,000 strokes, and identify new cases of diabetes each year. And the important thing is that this would be delivered by the NHS. It's important to realize that since then we've learnt a lot more, that the same cardiovascular risk factors that were being targeted in the program, blood pressure, high cholesterol, and smoking, and so forth, are also now implicated in the etiology of several other non-communicable diseases like dementia, sort of non-alcoholic liver disease, and certain cancers. So in effect, a health check program represents more than just a cardiovascular program. It is the largest non-communicable diseases prevention program in the world. So it's an important program to evaluate, which has generated interest not just in the UK, nationally. Next slide, please. Again, I'm sure most of you are very familiar with the NHS Health Check program and its composition. It's made of 3 key parts: CVD risk assessment in the first instance, discussion about risk awareness, and then risk management. So it is more than just a series of assessments. It's a package where a healthcare provider or somebody takes the time to do the risk assessment, but also then to have some plan of what to do with that information. It's commissioned by local authorities since April 2013, after it was introduced into legislation. And the idea is that every 5 years, people who are otherwise eligible and healthy, not with existing cardiovascular disease, already on treatment, aged between 40 and 74, get invited for one of these assessments. It's delivered by general practice predominantly, or other providers, including pharmacies and outreach services and others. And the main thing about the information is that the data that's generated needs to be returned to the GP practice. And I think by and large that does happen. And this is relevant because ultimately it feeds into how we evaluate this program. Next slide, please. Because it is such a prominent program, because it has such high visibility and interest, it has generated a lot of discussion over the last decade or so. And I'm sure many of you will be aware of some of these. But common concerns that are raised about the health check program is that because it's a prevention program that's by invitation, it might attract only those who are described as the worried well. People who generally have no real major problems but are curious and want to have things checked. There's also the sort of valid point, which is that there is no evidence of efficacy with randomized controlled trial data. There was no big randomized study of the National Health Check program to demonstrate its value, and it was implemented in a different way. But another common criticism is that uptake is generally quite low, and early studies had demonstrated low levels. So this was prior to it being introduced into legislation. And also comments that it's only certain groups who attend, for example, the older, white, more affluent population. And because of this, multiple observational studies have sought to try and look at these questions and use resources, either local data from a network of GP practices, CPRD data, and Curis data. Unfortunately, a lot of these studies have revealed variable results. And if you look through studies that have been published since from about 2012 onwards, you'll find a large variation in what people have reported. And we think this is primarily because there are small sample sizes, perhaps with regional variation, so it's not always nationally representative. A lot of studies were taking data from before the health checks was really rolled out from 2013 onwards. And so this has really identified a need for a national representative picture of a health check program that's not skewed by any local distortions, so we can understand really what we've achieved in the years that have passed. Next slide, please. And this is where we've been working. So PHE and NHS Digital have worked to create what we have called the data extract. And this is from the GPES service that NHS Digital provides. And this includes 90% of GP practices who have contributed to the health check over the years. So we don't have every single GP practice in the country, but 90% of these. And that's about 6,500 or so practices. And this covers pretty much all of the major GP system suppliers. And with this, we've managed to find 12.1 million patients who have an NHS Health Check code. And this forms our data extract. And I think the key message here is that we do have excellent England level coverage, so 90%, which is a huge improvement on anything that's been presented previously. Next slide, please. Now, I mentioned that we've got 12.1 million patients within this extract, but it's important to realize that these are patients who were included if they had a record of contact with a NHS Health Check program. So that means they were either invited for a check, they had a check completed, they didn't attend for a check, or was commenced or declined. So the check has to feature in the coding of that information. And this is important. I'll come to that in a second. And then the data itself includes important information like socio-demographic characteristics, key risk factors for cardiovascular disease, interventions that were offered and delivered, as well as CVD diagnoses. And more recently, we've also linked to HES and ONS to get outcomes as well. We went through a data cleaning process because even with the best will in the world, there are always patients who creep in, perhaps who should not have had a health check, or people who are outside the age range, etc. And after cleaning and sorting out the population, we managed to acquire about 9.7 million people for this analysis. Next slide, please. So this is the first piece of information that we can present, and this is the uptake of the NHS Health Check. So of all who were sent or invited, either formally through letters or on the day, how many people took up the offer of a health check? And you can see that there is approximately a 52% uptake rate over the 5-year period. And you can see that there's a slight sort of increase year on year, which seems to have sort of stabilized about 3-4 years ago, about 53%. So on average, about 1 in every 2 offers are taken up for a health check. Next slide, please. And this is the first important piece of information that we learn, is that there is a large regional variation across the country. And you can see immediately that this is why any locally performed assessment of the NHS Health Check may not reflect the sort of true underlying picture, contradict anything else, because there is enormous variation across the country. And you can see some areas are doing really well with uptake rates of around 80%. And then other areas perhaps with uptake much lower, more in the 30s and 40% territory. We've got a sort of a heat maps in the bottom right corner here, which also show the variation even within London. As you can see, that there's large variations with different areas and this is uptake. So this is how many people were offered or invited to a health check, and people took it up. Next slide. So then we next wanted to look at who the people taking up an NHS health check are. What do they look like? And what is their age profile, their gender, ethnicity, and socioeconomic status as the key indicators. And this is driven really by trying to understand, is there any evidence of inequity? Do we really see that it's the white, older, rich patients who are coming to these checks, or actually are we able to target pretty much all the people who should be targeted? Next slide, please. This is information about age and attendance. And so taking the 5-year data as a whole, you can see that we had around 2.9 or 3 million attendees who were under the age of 55. And that graph on the left just demonstrates just the volume of patients by age group. So this is the number of attendees. And for the first thing you notice is that it does decrease as you get older. Now that's not surprising, because to be eligible for a health check, you of course need to not have many of the age-related conditions that we normally associate with cardiovascular disease. So it's as expected that younger people would be more eligible and therefore more likely to be invited and therefore more likely to attend. The figure on the right then shows the attendance rate. So once you are invited, how many people attend? And there you can start to see by proportion that more older people do attend for the health check compared to the younger people. So proportionally, we do have more older people attending, and which is fine because these people are at high Q risk. But by numbers, we have larger numbers of younger people attending. And this is perhaps where there is an opportunity for prevention and interventions, which we can discuss in a little while. Next slide, please. So I'm not going to go into too many details. This is really all presented in the paper and in the dashboard, so you can delve into those in more detail. But top line numbers, as I said, is that for age, the age group of 55 to 69 are more represented in attendees compared to non-attendees, so they're more likely to attend. And it is true for younger people, so there are more non-attendees who are younger than attendees. But as I said, by numbers, those are very different. In terms of gender, we do find that more women are represented in health check attendees. So overall, we found that 54%, 54.7% of women were in the attendee group compared to those who did not attend. And compared to a national average of the sex mix, it's 50.9. So you can see there are more women who are attending for the health check overall. The next two are probably the most interesting because ethnicity and deprivation are the ones that are really sort of concerning when we talk about inequities. And one thing that was a pleasant surprise is that actually we do not find a significant distortion in representation in attendees and non-attendees by ethnic mix. If anything, we're finding that there is more attendance from ethnic minorities than non-attendance. So, for example, I've just taken one example of the Bangladeshi population. According to mid-2015 ONS data, they should represent around 0.4 of the population. Of those who are invited, they're about that same number, so that's good. And you can see there's a slightly higher number, or very small, marginally higher proportion seem to attend compared to non-attend. Now, I must caveat that there is a large amount of missing data in ethnicity, so we do have to consider that when we're understanding ethnic data. But overall, there is no clear evidence that there is a major inequality in who we're offering the tests to. And then similarly for index of multiple deprivation, we don't find any gross deviance. The only differences we find are at the very extremes of deprivation. So for example, in the lowest decile, we find there is more non-attendance. In the highest decile, we find there is more attendance. But beyond that, in pretty much the rest of the 8 deciles, it is very, very close with almost no visible difference. Next slide, please. The next element is about recording of CVD risk measures, and this is a kind of a Marmite type of figure. You either hate this or you love this type of figure. What it shows is how well we're recording particular risk factors, and the purple line is demonstrating what the picture looks like for attendees. The blue line is what the picture looks like for non-attendees, for the main risk factors that we are assessing during health check. And you can see, as expected, that things like blood pressure, smoking, cholesterol, things which are needed to assess a 10-year risk are very well documented. And that is in itself an achievement of a health check, that we have improved our recording of a lot of these important risk factors. There are lower levels of things like physical activity, and alcohol, which are not obviously mandated within these checks, within the CVD risk scores that were used before. And diabetes risk with glucose and HbA1c is interesting because they're quite similar among attendees and non-attendees, and we think that may be related to other sort of disease registries and diabetes efforts that have been going on in the past. But again, it's only done if in people who attend a health check and who may be at particular risk. Not always done universally, so that also explains why. But I think the take-home message is that risk factor recording has really improved dramatically as a result of the NHS health checks. Next slide, please. This is to demonstrate the proportion of risk factors that we've identified. Again, it's just a top sort of high-level snapshot of the sort of numbers we're looking at. But you can see that of all the attendees, we're finding around a quarter meet criteria for high blood pressure, about a quarter are obese, and so forth. Fact history is obviously very difficult because it's, if it's not there, it doesn't necessarily mean it's not there. It just means it wasn't recorded, I should say. Among non-attendees, the picture is difficult because of a large amount of missing data, and we've deliberately presented it like this so that we avoid the temptation to compare the two side by side, because obviously they're not directly comparable. Next slide, please. And these are pretty much the same information, just as sort of nuggets, if you like, to say that for every 4 NHS health checks, you find someone who's obese, and so forth. Again, I'm not going to go into each of all of these, but it's just a different way of presenting the data that we've demonstrated already. And the risk factors that we're finding are actually at a similar level to what we expect in the population. And we've looked at sort of Health Survey for England and other data sets which do tally up with the risk burden that we're identifying. Next slide, please. And there's some more, again, for, like I said, a quarter of people having high blood pressure, a proportion finding high blood sugar, and importantly, the last one, which is about a fifth of patients, or 1 in 5, identifies someone who's got a high 10-year risk. So that's obviously the most interesting CVD risk group, because those are the ones that we can offer particular interventions as per NICE guidance. Next slide, please. And then the next section is really about interventions. And we found that over the 5-year period, we calculated it, or we counted 6 million episodes or different pieces of interventions, either these are advice, information that was given in some form, printed material or otherwise, referrals, or even sort of just general advice, talking to patients about weight loss and so on. And importantly, these were given to 2.5 million people who were particularly at relevant risk. So, for example, if someone was obese, they got the relevant risk intervention. Overall, about 16% of all attendees received some advice on lifestyle and behavior. Half of all smokers were formally recorded as having smoking cessation referral, and 19% of people who were obese with a BMI of more than 30 were referred to weight management. I would caveat this heavily by saying that this is interventions that were documented and coded in the GP record. So obviously there may be more that was not recorded, but this is what was found in the GP record data. And then on the right-hand side, I've just shown you some prescription data, because again, this is something that's been debated and discussed. And I've said here that of the people who had a high 10-year risk, 20% were prescribed a statin, and meeting the sort of older criteria of 20% 10-year risk, we found out it was much higher, it was almost double at 40%. And this is quite good because it's close to the national ambition of about 45% target to get people who are above 20% risk onto a statin. And again, a caveat with this data is that prescription data was only available for about 60% of the data, because we didn't have it for one particular provider, but from sort of sensitivity analysis, we don't have any reason to suspect that there's any difference even within that group. Next slide, please. So before I sort of wrap up, obviously I've limitations of the data, and as you can all imagine, working with primary care data, as with any electronic health record data, there are multiple challenges. I think the first limitation to say from what we've done is that we did, of course, only include people who had a code for an NHS Health Check activity. So therefore, that means that we were unable to estimate eligibility and coverage. So I can tell you how many people in a particular area were invited or should have been invited. So were they or not? We can only say what happened after the invitation. But we do have other means of trying to gather that data, and PHE has good resources that can allow that. We estimate from sort of disease registers and excluding people who shouldn't be eligible and so on, that we probably needed to capture another 6 million people or so in that 5-year time frame to get to a target of 75% offering for health checks across the country. Missing data, as I've alluded to already, lots of missing data among non-attendees, so that obviously limits comparisons. And in later papers where we're going to try and compare what happens to patients with outcomes and so on, we do have to use or consider using sort of more advanced statistical methodologies to try and overcome some of that if possible, but it will never be perfect just because of the nature of the problem. But 10% of GP practices were not included. There may be an element of bias in that. We don't know why these practices were not participating and whether that reflects something else that could induce bias. We had limited data for people who were older, so between the age of 70 to 75, due to a problem with a business rule in the initial extraction of the data, which just meant that we lost people as they turned 75 during the 5-year cycle. And then prescription data, as I mentioned, was available in only 60% of our cohort. And then finally, again, as I've alluded to, this is all very read code dependent. So for interventions particularly, we can only say what was coded, and coding practices vary across the country. We do know that. So that is something that needs to be considered when looking at that information. And then finally, just because there's a read code for a health check, it does not mean that it was a high quality encounter. And that is something that we cannot assess using data like this. Did someone spend time really trying to express to a patient or a person what the meaning of their risk score was, what the benefits might be, and so on. We can only hope that happened at a large enough number. Next slide, please. So in summary, the sort of take-home message from this first overview, if you like, of the health check program, a descriptive summary, is that 52% of people who are invited for an NHS health check take it up. There is significant regional variation, and we need to do more work to try and address that. There's no clear evidence to suggest there's any gross evidence of inequity in invitations or uptake, particularly by ethnicity or IMD. We acknowledge that there are more women turning up and a slightly older cohort turning up, but that is something that has been recorded multiple times previously. Recording has improved significantly, and I think that's really important, because if you have that data, then can you act on it. It does reveal a high burden of risk in England, but equally with that come the opportunities for prevention, particularly in the slightly younger age group who may benefit from smoking cessation and other evidence-based interventions. And then importantly, there's encouraging levels of interventions are being offered with NHS Health Checks, and these are all evidence-based interventions. Of course, we could do more, and there are lots of things that we should be doing more, particularly around inviting people who are eligible, who are perhaps not being captured yet, about 6 million who are missing, trying to work hard to try and reduce this variation across the country in uptake, and in particular prioritising the non-attenders who may be at higher risk and who do have risk factors, but unfortunately we are struggling to try and get those into the programme. So there's a whole load of work that's being focused to try and target those individuals. Next slide, please. And final slide is to say that, as I mentioned, there are lots of other projects that are coming with this data set, looking in more detail at risk factors, about people who have multiple risk factors and what they look like and what the health check tells us about them, about the interventions, about inequities or whether there are any inequities in interventions, what's happening with long-term, short-term cardiovascular risk in young people, older people, and then finally the outcomes, which of course is interesting. It's probably too soon when you're thinking about prevention to look at death and mortality and so on, but we are linked to HES and mortality data, and we will be reporting on things such as new disease diagnoses, as well as any evidence of any impact on hospitalizations and mortality. I think I'm nearly done, but one last slide that just highlights, I think, so the link to the paper, the dashboard, which I think there's another webinar, as you can see there, on Tuesday, the 1st of December, and more information about how this data was extracted. I think I'll finish there and hand back to Jamie. Thank you very much.
Riaz, thank you so much for walking us through the this first paper and the first analysis that's been undertaken. And I probably should have started at the beginning of the session of just paying tribute to a big cast list of colleagues that have made this happen, and actually the journey of which we've been on in one kind of securing this data and the investment, the time that it had taken with working through colleagues at NHS Digital, but also the colleagues we've worked with through the department and through PHE and much wider. So, and obviously, really important to remember, local commissioning teams that, without you working with local colleagues and providers in capturing this data, there's no way we'd be able to do any of this analysis. So it's a real team effort from colleagues working across the country nationally in allowing us to do this analysis, and the many years it's taken us to get to at least this stage. But any program of this size, warrants really good evaluation. And so it's great to see these kind of initial outputs, and no doubt you'll be hearing from the team about the future outputs that are planned and future follow-up analysis that will be undertaken, and again for further extractions. But just a huge thank you to everybody that's been involved in this. And having been involved in the program for many years, for me, it's great to now see these outputs and start to answer some of the big questions which you've touched on, Riaz. But I particularly reflect on and remember some of the very early criticisms that a program like this would worsen or exacerbate inequalities, and that we would see significant or greater uptake within the most affluent communities, which this and other studies have demonstrated isn't necessarily the outcome of what we're seeing, and again comes down to really strong public health leadership around commissioning and delivery, and where teams have been working really hard in trying to make sure this programme is reaching some of our most vulnerable high-risk communities that we know will benefit from a programme like this more than perhaps certain parts of our population. But so it was good to see this evaluation also signalling that alongside other papers and others that have reported similar findings. The other thing that struck me as well from this evaluation was I remember when we were describing the programme in the early days, and again a common criticism was this happens anyway. So what you're setting out to do in the NHS Health Check programme is just standard routine primary care. So you're just duplicating efforts. It happens. And actually, I think this analysis alongside others has demonstrated that routine primary care doesn't necessarily mean that everybody out there is getting their smoking status recorded, they're getting their BMI or their blood pressure recorded, or particularly things like their cholesterol or cardiovascular risk recorded. And I think the overwhelming conclusion from this piece of work is obviously those people that attend the health check are far more likely to have those things recorded, and later analysis hopefully will demonstrate acted upon. But there is room for improvement. There's significant room for improvement how we continue to enhance and improve delivery. So again, Riaz, thank you. This has been really helpful.